Hi, everybody. I'm Ida Uester. I'm with the Big CISA Center for Health Journalism. Thank you so much for joining us. I think it's going to be a fascinating discussion in preparing for this webinar called Hotter Days, Sicker Lungs. I met the two scientists, of course, whom we'll be speaking to today, and their science is fascinating. I'm sure people in Cape Town hope it won't get any hotter than this. Predicted to get up to 42 degrees today. So we'll hear what that does to our lungs and what other factors do to our lung health as well. According to the percentage of people who suffer from asthma specifically, there must be some people on this call who have asthma. And I think some of what you'll hear might be disturbing and worrying, but some of it will also please you because Professor Jonny Peter, who's an expert in that field, can tell us why it's not all doom and gloom in terms of this connection between climate change and lung health. This webinar is brought to us thanks to the Wellcome Trust, who are supporting Big CISA with the Climate Health Story Project. And that's really about bringing journalists and scientists together to look at areas of climate change that impact on our health. So that's what it's about. The other speaker, Professor Rebecca Garland, will tell us is an atmospheric scientist, and her science is something that I think journalists don't report so often on. We report on the weather, and we know that our audiences love following the weather, but there's a difference, of course, and she'll explain to us what that difference is. So that was a bit of an informal introduction, but I think the fact that you joined here means you're interested in the subject. I certainly have become so much more interested since speaking to these two scientists. Thank you so much for all the very many, very good questions we got in response, on the sign-in forms. We'll get to those questions. As you know, this webinar is an hour and a half long, and at the hour, we'll certainly go to the questions. I also wanted to alert you that there'll be a poll that pops up at a certain point. Please look out for it and fill it out. Fill it out before you leave, please. I'll send another reminder, but it won't come out quite yet. It'll come up a little later. So I think with that behind us, just to say, feel free to interact at any point. I think some of the science we'll hear today is new, but both scientists really excel at explaining the science and making it relevant for our lives. So why does this topic matter for journalists? Climate change does not act alone. It's not that climate change directly impacts on our lung health. And, if you've read this short blurb, you might have come to that conclusion. But there are areas of lung health that are certainly impacted by lung health, but there are also areas that we can do something about. So that's why we framed it as not all a doom and gloom stories. And the two scientists we'll hear from today will tell us much more about that specific connection and how, very importantly, we can tell a story about this issue, because when science is complex, we can either turn away as journalists, or we can say, let me tackle it because it's of real use to our audiences, because there's something they can do. It's not a doom client science story. So with that, I've mentioned a little bit about each of the speakers, but I'll ask them in order, Professor Jonny Peter first, and then Professor Rebecca Garland, to introduce themselves just a little more before we go into Professor Peter's presentation, which will come first. So just tell us a little, Professor Peter, where you work, what it is that you do.
Yeah, good morning to everyone, and thanks very much for the invite to participate in this webinar. I think it's really, we saw this with COVID, but certainly within our university structures, we are talking a lot more about engaging with the media and helping our science to translate into stories that the public can follow. So I'm based at the University of Cape Town and the University of Cape Town Lung Institute, and I head up the division of allergy and clinical immunology. And my research domains are really threefold. I am a specialist in drug allergy, so examining how drugs interact with the human body and cause kind of allergic reactions of various kinds. I'm then also very much interested in the field of urticaria and angioedema, which are a particular kind of skin reactions in allergy. And then my third area, which is relevant to today, is that we have been interested for a long time now in how aerobiology, or particularly pollen in the air that we breathe, interacts and causes and worsens allergic respiratory diseases. And that's the kind of main research domains that I focus on. And I have now a unit of about 50 or 60 researchers across different, from clinical to basic science, and now increasingly as well, also with a strong community engagement aspect, so that we can really try to understand what people are thinking about in terms of their health, respiratory health, in terms of their health priorities, and use that as well to shape our research questions and our research involvement. And similarly to that, that's part of the reason why it's great to be on a call like this and a webinar, and really get an opportunity to hear what people think and are interested in knowing.
Thanks, Professor Peter. And I think you're the first registered allergy specialist in South Africa.
I'm the first registered allergist that focuses on adults. So allergy as a discipline, you're absolutely right, was only kind of came to South Africa as a recognized subspecialty with the HPCSA in 2016. There are a couple, tends to have been quite a lot of early focused on children, but adults also have a growing number of allergic needs and allergic problems that we are particularly focused on. Yeah.
Thank you so much. Professor Garland, tell us more about your field of study and, of course, why this interests you.
Yeah, thank you. Thank you for inviting me today. I'm really excited for the discussion. It's a little different of a framing and really integrated, and I'm quite excited to hear the discussion today. So I'm Prof. Rebecca Garland. I'm at the University of Pretoria in the Department of Geography, Geoinformatics, and Meteorology. My group focuses on atmospheric chemistry, atmospheric composition, and air pollution, mostly in South Africa, some in Southern Africa as well. So, we use a lot of information from models, from measurements, from satellites to try to understand not only what the current levels of pollution are, but also trying to understand, working in collaboration, really the drivers and kind of the cycles of the pollution through the system, and also down through to the impacts. And that, is one way of framing that we hope to then better understand how this could change under global change. Because in South Africa, we have a lot of sources from anthropogenic, from people emissions that we create, but we also have really strong natural emissions that also might be changing. Not just pollen, but felt fires and things like that. So when we start to bring in climate, and as I'll show in my presentation, there's lots of different linkages, and one of them is trying to also understand what is happening right now in order to know what could happen into the future. And it's interesting that you say, it's not, air quality isn't something that gets too much attention. I find it gets a lot of attention when it starts to smell. That's when I start to get calls. But the air pollution, we generally can't smell or see it. And so it's great to also talk about it. Yeah, no more general sense.
Thank you. That sounds fascinating. And I also wanted to let you all know that Professor Garland has contributed to major international assessments on pollution and climate change. So we have two real experts in their fields. And we're marrying the two fields today in this discussion. So, Professor Peter, over to you with more detail on the subject we're exploring today, please. You're muted. I'm not sure if you know that.
Sorry, couldn't find the unmute button for a moment. Right. Can you see the slides? All right.
Yes, thank you.
Okay, wonderful. All right, so really my focus in this short presentation is to try to help the media understand about the kind of landscape of respiratory health in South Africa, and then to use asthma really as a model to help you to try to understand all of the myriad exposures from our environment that can impact and drive changes in asthma, and then how those may be altered by climate change. We've been working recently as well to try and kind of think about all of the aspects that encapsulate some of the work that we do. And that's part of the reason why we came across this logo and developed it. Really, if you look on the first side, it's about the focus of mapping and monitoring and measuring, which is a real big focus of our research work. And then the second part of that is around using that data and that information to impact change and actually improve people's health. So we have a lot of respiratory health burden in South Africa. The traditionally well understood burden is around infectious diseases. People may be aware of the burden we've had of respiratory infections in terms of pneumonia and particularly TB. And then, of course, because we're a country with the largest HIV co-infected persons, we have a lot of opportunistic pulmonary infections that are linked specifically to HIV. Then we have a not insignificant, and I'll show you the figures, burden of chronic respiratory diseases in terms of both allergic disease, but also in particularly in the older adult population, what we call chronic obstructive pulmonary disease. And chronic obstructive pulmonary disease is really almost like a final common pathway for several damaging lung problems, which largely center around smoking, and in our context are also aggravated by HIV, TB, past infections like linked to that, and also even substance abuse. They all kind of play in together to make us have a particular problematic burden of chronic obstructive diseases. And then also important, but not necessarily a cause for mortality so much, but a cause of a lot of morbidity, absenteeism from work, and impact on the economy in terms of cost, are actual upper respiratory problems. And in the case of allergic disease, particularly what we call allergic rhinoconjunctivitis, lay people know this as hay fever. So that's the kind of landscape when we're talking about respiratory health in South Africa. So where do we sit if you now try to think about respiratory diseases in South Africa and the impacts or burden potentially from a changing climate? So what is encapsulated in this slide, and this is a review article that we will be happy to share, that I think covers a lot of what I'm talking about in this presentation. What is a particular challenge in our context is that we have several socioeconomic and structural determinants that drive many aspects of respiratory health. So I'll show you in the example of asthma how there can be links to particularly poverty and poor environments that worsen access to healthcare. We've had changes and rapid urbanizations. We've got many problems in our healthcare system that impact the ability to access treatment, and as a healthcare service, we're actually got a very limited number of subspecialist respiratory physicians, and as a result, majority of asthma care is given by primary care physicians. Then, in addition to those environmental exposures, we have a very significant burden of indoor exposures and air pollutions, and these have clearly got very strong links to respiratory diseases. I've mentioned already the intersecting relationship between TB and HIV, high prevalence of smoking and their impacts on lung disease. And then I'm going to show you the figures about the burden. And then I think just as a framing for health impacts that could be linked to climate, people tend to use these three headers. So it's quite a good framing for the media. So we first talk about direct impacts. The examples there might be what we're experiencing now, a heat wave. What is the direct impact of that on respiratory disease? Then there's indirect impacts, which often come over a longer term. So I'll show you a little bit of our pollen data and the predicted impacts from climate change on pollen levels. And then shifts in respiratory infections are another thing that is being talked about together with migration. All of these things can impact respiratory health. And then, of course, the other thing to think about is all of respiratory diseases are not equally distributed amongst different groups, right? So pediatrics and children, particularly for asthma, are a very vulnerable group. I've mentioned an older burden and growing disease of COPD. We worry as well always about pregnant women and outdoor or informal housing residents. These are particularly groups that are potentially vulnerable to climate impacts. We have focused a lot of our effort, and the work that I'll show today is really around asthma. And the reason for that is that asthma is a condition which is very responsive to the environment. And what's part of the definition, in fact, of asthma is that people have what we call diurnal variation. So they change in their symptoms over the course of the day. And what the disease is it's a disease of the medium to small airways, which you pictured on this figure. And essentially, it's an inflammatory disease that has both kind of acute and chronic inflammatory elements that lead with exposure to a trigger. And I'm going to show you multiple triggers. The airways change from these open, nice, wide diameter airways to an airway that looks more like the one on the left, where you see that it's constricted, the airway is narrowed, there's a lot of mucus being produced over time. Chronic inflammation includes smooth muscle changes and proliferation, lots of immune inflammatory cells that change. But you can imagine that simply if you just look at the physics of breathing, when one changes from the airway on the right to the airway on the left, or the one that's thickened versus open, you can see that you get almost immediate effects, and these can be quite dynamic over the day. So that's the first thing that makes asthma quite an interesting and important disease to study in the context of an environmental exposure risk. The second is that asthma is a really interesting disease in that it's got endogenous or kind of host risk factors. These include genetic risk factors, but also other comorbid diseases that can impact. For instance, we know that obesity and increasing BMI can negatively affect asthma. There are several social determinants of asthma health and morbidity that have been demonstrated. And then, of course, what we're going to talk about today more, which is really the things that we breathe and how these can impact asthma. The other reason is the fact that asthma is an incredibly treatable disease, and we have very effective treatments for asthma. And this, what I'm showing here, is a combination asthma inhaler called Symbicort. And the reason I'm showing you is that this is on tender in the public sector. So this is something that any patient accessing a primary healthcare clinic in South Africa can get access to. And the great advantage of this is that this allows something in asthma called smart therapy. And what this is a combined maintenance and reliever therapy. Okay, what that means is that patients get a bronchodilator, which opens the airways, as well as a steroid anti-inflammatory, which deals with that chronic immune infiltrate that I was trying to describe on the previous slide. Smart therapy, what's great about it too, is that it gives the therapy to the patient to allow them to dial up their therapy as they start experiencing increased symptoms in the community. And there's some very elegant, substantial body of evidence that's put this therapy into guidelines, which has shown that if people use this therapy, they can decrease the amount of severe asthma exacerbations, they can reduce people getting into hospitals, and actually they decrease the overall burden of therapy in total. So what we feel is that if we can be responsive, if we can have a dynamic interaction between environmental monitoring and the asthma community, then patients already are equipped to be able to impact positively their treatments and their outcomes. And that's why I think it's a particularly important and useful disease to look at. The next is, of course, unfortunately, the burden of asthma is significant. And I think Ida mentioned this right in the beginning, that up to 1 in 10 people will suffer with asthma in South Africa. This data is very recent data from KZN, looking at a large adolescent population. And you can see that we had higher overall risks than the global asthma average. And we also had a significant burden of severe asthmatics. And I put here at the bottom the associations with severe asthma, because I think this relates to the previous slide I was talking to you about risk. So this is around school access. There's the endogenous factor, there's air pollution, smoking, there's other allergic diseases as well. So this is in particular evidence slide around the local epidemiology. Sadly, we also have another claim to fame in the asthma world in South Africa, is that even though we don't rank, we rank about 14th or 15th in terms of prevalence. So I showed you we're a little bit above the global average. Unfortunately, we are one of the top countries for asthma mortality. Now, that could be for several factors. There could be, again, genetic factors related to our population. There could be social determinants. There could be health system and access to treatment issues. And then there also could be unexplained groups of environmental factors that are influencing. Also, on a positive note, having this kind of position means that there's lots of room for improvement and lots of place where this kind of research that we are doing and others are doing can impact this. So then I thought that these slides for this particular group would be useful to put together. What I decided to put together was 3 slides that try to highlight and synthesize in a very succinct manner the current data that we have on the association between weather, pollution, and pollen and asthma. So what you're seeing on this slide is related to meteorological changes. And you can take a picture of this, and I'm not going to go through every details, but I want to highlight a few points. So the first is that when it comes to weather, both high temperatures and cold temperatures that are extremes can have impacts on increasing asthma related ER visits, that's emergency room visits, the worsening of lung functions, which is measured by this metric called the FEV1, as well as the chance of exacerbation and even deaths. And the same, we see that for very high and very low humidities can actually have that. So weather can do it on both sides, have an impact. And then one particular thing that has put pollen monitoring in certain parts of the world really on the map is this condition that was described best probably in 2016 from Australia, is this concept of thunderstorm asthma. And what happened there was in 2016, and over the course of 30 hours, there was a sudden spike with over 3,000 ER admissions during that time. And there's subsequently been a lot of research on that has demonstrated that the requirement for and the reason for this happened was it primarily related to grass pollen, and so the height of the grass pollen season, together with a high electricity thunderstorm front. And the coming together of those led to rupturing of pollen grains, which exposed a lot of allergenic protein, and that really had a very aggressive effect and led to this huge spiking in asthma admissions. There have been descriptions from it other parts of the world. We have not been able, because of our health system data, to yet understand whether that is going on in South Africa. And yet we have, and Rebecca may even talk to this, we have a very high rate of thunderstorms in South Africa. So that's an example. And that single event actually in Australia led to a huge increase in environmental monitoring. And they now have some warning systems at a national level that occur in relationship to that. Similarly, other rainfall and wind can have effects. Then there is a considerable amount of data on different types of air pollutants, and we'll hopefully hear more from Rebecca on some of the details of this. But what I'm putting here is, and I wanted to highlight, is really the key ones that have been linked to worsening of asthma. The first is particulate matter, and that comes in different sizes, and that's what you're seeing here. Particulate matter 2.5 is smaller, it's a micrometer, then 10, which is a larger particle size. And you can see I've put underneath here what they come from predominantly. Okay, so these are very common exposures, for instance, traffic and combustion, construction work, and such similar things. And these are all, particularly PM 2.5, has a very strong risk of driving worsening of asthma. You might hear more as well about ozone, because ozone is something that is thought to be really climate sensitive and increasing. And certainly ozone has a very strong association with driving worsening asthma. And then some of the other gases as well are linked as well to increases and are often quite specific to particular industrial admissions. The one thing maybe to highlight on both this slide and the last is you'll see that individual sizes of risk increases are often not necessarily that big. So they might be 5%, 3%. A couple of them, like the ozone one, may stand out as larger, but essentially the individual risks are still quite small. And then the area that we've spent a lot of time focusing on is the bioaerosols. In particular, we're interested in pollen, and I mentioned thunderstorm asthma linked to grass pollen. We see very high rates of grass pollen sensitization in Cape Town. We have quite a unique southern hemisphere grass pollen sensitization, with our leading species being Bermuda and ryegrass, as opposed to northern hemispheres being Timothy. We also have a range of usually ornamental tree allergies, with less of our endemic species, particularly in the Cape, being allergenic, but people definitely are sensitized to those. Also, we are interested now in studying how fungal and mold communities will impact allergy, largely because of this very strong link, particularly with the mold Alternaria, which is an endogenous environmental mold found frequently and widely distributed over South Africa, being linked, certain proteins are linked with a more severe form of asthma. One can understand very quickly how bioaerosols can be linked or interact with weather, because weather changes are the main drivers of how the shape and the way in which the pollen dynamics will occur. And this has been shown now in several studies, a link between heat driving more pollen. Rain actually has an interesting effect where in the short term, it can wash pollen out of the air during pollen seasons, but early rain and heavier rain in the winter tend to associate with more intense pollen seasons. And then also increasingly, we're now seeing synergistic negative effects between pollen and air pollution. And this is a particular area with limited data, but the data is increasing and warrants further study. And then from a kind of biodiversity perspective, South Africa is incredibly interesting, right? Because we have these different biomes. We also, if you look at megadiversity across the world, 36 regions of megadiversity, we have an entire fynbos biome that is on the megadiversity list. It's one of the only megadiverse hotspots in the world that spans only one country. Interestingly, fynbos pollen is not allergenic. It tends to be heavy and doesn't get very far in the wind and into people's noses. But of course, the difference in our climatic zones across the country, the different biomes, make the bioaerosols of the country very interesting and quite different. And we had set up in 2019 this South African pollen monitoring network. You can see here the spots in red where we are monitoring, or our monitors have started to come up. We've also been taking this direct to the public with the Real Pollen Count website. Some of you may have heard me talking on the radio, doing things to try to get people to engage, to learn about their allergies, to try and connect any of their symptoms to pollen counts. This is now the leading pollen site in Africa. We get quite a lot of views. Often it picks up usually during the pollen season, and then in the intercurrent periods is less important. But on this website, we put a lot of information for allergy sufferers, information about the common species. So if you want to check that out, it's a very useful reference. And then what about climate change and bioaerosols? So importantly, in the context of pollen, there's a lot of data largely from the northern hemisphere, which shows that pollen total amounts will go up with increasing temperature and CO2. And actually, alarmingly, the allergic proteins can increase proportionately in each grain of pollen. And then with the changing climate, we will actually see allergenic species migrate either further north or south, and that will lead to new allergy sensitizations. And then there's been a lot of studies now, and ongoingly we're looking at with our data about the length of the pollen seasons and how they will change. Interestingly, it's not completely uniform. So for instance, trees seem to be extending in the length of the season, whereas grasses seem to actually be shortening, but be potentially becoming more intense. So I think there it's important that we develop local data. So what do we think, given all of that background now? I want to end by just posing what I think are the key outstanding clinical questions around asthma, environmental exposures, and how these might be impacted on by climate. So the first is we need more data on outdoor exposures and meteorological risk. So are there very high risk periods? So I showed you that example of thunderstorm asthma. There is no local African data on that question, right? So in order to do that, you need to put together the kind of asthma data at the systems level. You need to be tracking that, keeping that, and then you need to model that against the environmental exposures to see, are that happening? And of course, in these very high risk periods, these are what the public health system might want to go after, because I mentioned to you the small attributable risk of an individual kind of risk environmental exposure. But when these things come together, there might be these very high risk periods that warrant warning systems to be released. Then there's definitely more needed to study about integrating indoor, outdoor exposures together around an individual asthmatic. There's lots of work that still needs to be done on that. And then, of course, translating these sort of proximal exposures to the climate, this is also gaps that need to be done. So how are air pollution, meteorological variables, pollen, how are they actually changing under short and longer term climate exposures? There's still a lack of data from that. And then community level monitoring. This is something that we are very interested in. If I've got, do I need one monitor in a community, every community, even if that's 5 Ks away, or is it good enough to just put one monitor in a particular climatic zone, and that can be representative and useful for the community of asthmatics at different distances? We are very much interested in getting more local data on extreme weather, and that ranges from floods to wildfires to heat waves. And then what we don't even know from South Africa, because we've actually lacked the data, is are there particular hotspots? We know that there are hotspot regions for pollution. We know pretty much with some degree of certainty the main types of pollen in the air and when they occur, but we haven't really analyzed, are there certain areas we should be focusing more attention? And then the last is an community engagement piece, which is really how do communities with all other pressures, mental health, infectious diseases, economic pressures, how do local communities see the importance of asthma, importance of what they are breathing, and also how they see our changing climate? And that, of course, is going to impact and be important for how susceptible or how amenable they are to interventions that we might suggest to them. I think I'm going to stop there. I think I've gone in 20 minutes. And I think if we have time in the questions, we can talk a little bit more about what our team is trying to do that and our new Wellcome Trust SA Cares project.
Thank you so much, Professor Peter. Just quickly, I see there are quite a number of journalists on the line from there's journalists from Zambia, Uganda, Zimbabwe, Kenya that I see on the line. I mean, it was very disturbing to hear how high our HIV prevalence is in South Africa. But I would imagine that many of the factors you're talking about would apply to the countries we've just mentioned, and that, similar trends can be seen. Is that right?
Absolutely. And when it comes to environmental monitoring or respiratory health data, sadly, in many other countries in sub-Saharan Africa, the data is even sparser. So there's even less data. But also, the HIV is one particular driver, but all of those other social determinant helps, like you saw that slide around asthma burden being linked to fee-paying schools, BMI, and smoking, traffic, those things, those are found across low middle income country African settings. So they are highly relevant across the continent.
Thank you. Okay, so Professor Jonny Peter has shown us what happens to our lungs when we're exposed to things like pollution and pollen and extreme weather. And now we're going to step back and look at the other side of that story. What is happening in the air itself? So Professor Rebecca Garland will tell us now how heat, pollution, and atmospheric conditions shape the air we breathe. Thank you so much, Professor Garland.
No, thank you very much. Just getting my screen shared. Okay. Thank you again for inviting me to this conversation today. I am going to focus much more on the air quality aspect, particularly with a view of, it being, particularly in South Africa, something that, as Prof. Peter said before, something that can really contribute to and exacerbate the situation that we're already in, and can have impacts and can change through under climate change. But it is also something that is something we can control. We can improve air quality in South Africa. We do know the measures, that need to happen. This is focused in South Africa, my discussion. A lot of it would be applicable. Thank you, Ida, for noticing that there are journalists elsewhere, also outside of South Africa. And actually, one of the, I didn't put it in here, but I'd be happy to speak about it if it's of interest. There is an assessment for African air quality that was a Pan-African assessment that showed what type of pathways different countries in Africa can take in order to really improve its air pollution. But I don't want to get too sidetracked. First, I just wanted to introduce myself as well and what my group does. So my group at the University of Pretoria, as I said, we focus on atmospheric composition and air quality. We use a lot of different sources of information. You can see in those little blocks there. And a lot of this is because we are in a data scarce region. And so when you start to integrate different types of measurements, different types of information, we try to reduce the uncertainties and be able to better say robustly what we do know and what we still have too large uncertainties in. It's kind of given some of the answers of what I focus on really right now, but I just wanted to highlight the South African context. And as I said, I'll go into some aspects of these. So we do have really strong policies for air quality. However, our air quality is poor, and it's not been improving as quickly as it needs to in order to meet our standards. There have been some improvements, but not as much as we really need. We do have air inequality, where often it's the most vulnerable, the poorest communities are exposed to higher levels of pollution. And as noted with climate change as well, they're often most vulnerable to that as well. And as I said in my introduction, we have really large anthropogenic, so sources that are coming from people, usually, as I'll show, from fossil fuel burning. We also have natural sources of pollution, such as wildfires and lightning, and I'll show some of those as well. And of course, aerobiology. When we think of air pollution, I often think of it through the impact pathway. And what I'd like to highlight today is just examples across this impact pathway of what we know about air quality and talk a little bit about the linkages to climate as well. So I've gone a bit broader than just heat, but heat does, of course, play an important role across many of these. So for example, I'll talk a bit about emissions. So pollutants can be emitted, they go into the atmosphere, they can be transformed through chemistry. So for example, ozone is a secondary pollutant. That is a pollutant that is only formed in the atmosphere. It is not something that is emitted from an activity, but it is the gases that are emitted from activities that form in the atmosphere, that react in the atmosphere, to form ozone. Meteorology has an impact, and so it can move the pollution around until we get to the ambient concentrations, and ambient are the outdoor concentrations. So a lot of what I'm focusing on is outdoor pollution. And then people can be exposed to it and there can be an impact from them. And I'll provide some highlights across the impact pathway as we go on. Just to note that I will focus mostly on ambient, on outdoor pollution, but we do also have high levels of indoor pollution, particularly in houses that use solid fuels or liquid fuels for domestic heating or cooking as well. And those have a large impact on the outdoor air as well. So when I talk to people about, what's typically like in South Africa, and particularly a lot of my work focuses up here on the Highveld, I generally say, well, we have lots of sources and we have very unfortunate meteorology. If anybody is in the Highveld right now or up here in Gauteng, we are starting to see this where in the winters, we have a lot of air that doesn't move and it traps a lot of our pollution. What I'm showing here is one example are the biomass burning, which is a source of pollution. Here, this is from a satellite where we can see this river of smoke coming off of Durban, but it's actually the pollution that's been throughout the burning season, just really circulating around the whole Southern Africa region. And then in South Africa, we also have areas, as we all know, right, where the veld will burn during the burning season, which impacts our health, which impacts air pollution. We have community-based sources. This is a picture of someone cooking outside, but there's also cooking inside as well. And then if, for example, if waste isn't collected, waste can be burnt as well. And so these are ones that, really then linked to socioeconomic status and as well. We have large amounts of traffic. This is just a picture in Johannesburg. These are paved roads, but of course we also have unpaved roads that can contribute. We do have industries. You might have seen pictures like this. This is from a satellite. This is showing the NO2, so one of the pollutants from fossil fuel burning and combustion. And you can see here, these are our ESCOM plants. If you can see the little dots, there's even the dots up in the Waterberg. We're in this one satellite image, we can see the plumes coming from ESCOM. We also would see the cities, but Johannesburg is Gauteng's kind of under this plume, but we do see Cape Town coming out as well. And I'll talk to this a little bit more as well. And then we have additional natural sources. Jonny brought up the thunderstorm linked pollen. Thunderstorms and lightning rather also produces NO2 as well. And so this was a study by a student who looked at NOx, so similar pollutants to down below here from the scan that we see, and she found that there's, the highest emissions of NOx are kind of also over the Highveld as well, because that's where we have a lot of lightning. And then we have emissions from trees as well. These we call biogenic volatile organic compounds, and these together with this NOx and this NO2, this is what forms ozone as well. So it's not every source that we have, but we can see we have a lot of range of them. I'll talk a little bit about the priority areas, so just to put into geographical perspective where those are. So we have 3 air quality priority areas: the Highveld, which includes Mpumalanga and goes into Ekurhuleni. We have the Vaal, which is the south of Gauteng and goes into the Free State. And then we have Waterberg Bonjanala, which goes across 2 provinces as well and includes Rustenburg, but also in the Waterberg where we have our Eskom power stations. These are particular areas that are managed by national department in order to improve air pollution, but not the only areas with high air pollution. Very often in cities, we still also have high pollution. But just to note the geography of these kind of cross-regional aspects that are a focus of the government. And actually, sorry, I'm going to show a picture here of the Vaal. So this little one that's just south of Johannesburg down into the Free State. When people ask if we have a problem of air pollution, I like to show this picture. I know it has a lot of information on it. I'll just show you kind of first see where we are. So this here is the Vaal Triangle. If you can see it in black on both of these pictures, this is the ring road in Johannesburg, if you're familiar with Gauteng. On the left-hand side is PM 2.5. On the right-hand side is ozone. These are from a model. They were used for an air quality management plan. The key aspect is that any area in red is exceeding our standards, was simulated to exceed the national standards. The national standards in South Africa are set at a level in order to protect health. So we can see that when there's an area of red, health could be at risk. And so for both PM 2.5 on the left-hand side and ozone on the right-hand side, most of the area is red. And this is not something unexpected. And this is not something that is only relevant to the Vaal Triangle. We see this across urban areas and industrial areas, really, in many areas of the country, and particularly for the particulate matter and ozone are really what drives these exceedances of our national standards. And I'll come back to talk about the national standards again, so you can just see it's National Ambient Air Quality Standards, or NAAQS, when I see that. I added a slide at the last minute because Jonny was talking about NO2 pollution, and so I wanted to highlight that as well. So here, this one was PM, then on the other side is ozone. NO2 pollution is also, we have high levels of this, and particularly we see this in urban areas. So what I'm showing here is the concentrations of NO2. So this was the pollutant, if you remember, we could see from like those trails from Eskom emissions. But what we're looking at in this picture is work my PhD student has done looking at ground level concentrations. And ground level concentrations we've shown here over the Highveld is really concentrated in the city. A lot of sources of NO2, one main source of NO2 in particular are vehicle emissions. So NO2 is from fossil fuel combustion and particularly vehicles. This would look a little bit different than if you've, this would look a little different perhaps then sometimes what we see, I know this gets into the media quite often. People talk about this, how we have a hot spot over South Africa. So this is a picture from a paper. Oops, this is a picture from a paper on the NO2 hotspot. So again, NO2 is one of the pollutants that has a negative health impact. And you can see, if we look using satellites, we can see that it's over the Highveld in general. But what this is showing us, it's the satellite sits at the top of the atmosphere and it looks through the whole atmosphere. So this levels in red on the left-hand side, this is pollution in that whole column from the top of the troposphere all the way to the ground. We don't know where it is. What's on the right-hand side is ground level. And this is what we would breathe. We don't breathe, even if Eskom emits it way up high, I don't live on top of a smokestack. I live on the ground. And so a lot of this hotspot that we see that's over in Mpumalanga, that is up above our heads and we're not exposed directly to it, but we're rather exposed to higher levels in the urban areas. That pollution that's from the tall stacks does eventually impact us, but it usually gets dispersed before it comes down to us. So we can see that again, in the urban areas and industrial areas, we have different pollutants that have high levels, and a lot of these, and as I said, a lot of the exceedances of our standards are more to the PM and the ozone. We do particularly near highways and near high levels of traffic with lots of vehicles would have a lot of NO2 pollution. So just a very brief, very quick introduction to, the status of air quality in South Africa, which is we do have problems. But I wanted to then start to link it into climate and also energy and health. You would have noticed, I think, a lot of the sources I kept bringing up were the combustion of fossil fuels. And so that is a large source of emissions, both for greenhouse gases as well as air pollutants. And so one of the key linkages is that they both have similar sources. That both the air pollutants and the greenhouse gases have similar sources. And so action on one can impact the other. And I'll show in a little bit, not always a win-win situation, and we need to look into that. But also, these air pollutants themselves can warm and heat the atmosphere. And I'll show a slide on that just next. So they themselves can impact onto climate change. Climate change impacts on the meteorology, which can cover impact temperature, humidity, transport, so many things, which then would also impact what we are exposed to. So if you remember from the impact pathway, this is linking both the emissions, kind of what the concentrations are and what impacts they have, but also the transport of them, how they will be transported, and even the chemical reactions that will happen. And so they're really very strongly linked. As I noticed, some of the air pollutants also have an impact on the climate directly as well. They can cool, they can warm the planet. I pulled this from the most recent IPCC assessment report, so the Intergovernment Panel on Climate Change, where they've, for the short-lived climate forces, which is what they call these air pollutants that can impact on the climate, where they've summarized the state of the science. And I quite like this picture because it highlights, some of the different pollutants we've been talking about. And if they're in orange, they warm. The amount of warming and cooling is by the size, things going crazy, by the size of the Earth. And then we have other pollutants that actually can cool the atmosphere. And so there's this interplay as well between them. But that's not the only way that climate, energy, and health, air quality are linked. They're also linked through the health impacts. And Johnny's already given a lot of details on this, but I just wanted to highlight, through this figure, which I think puts it quite well, where we have emission sources, again, of air pollutants and climate change. And these can all have these impacts on public health. So while they impact each other, they can have similar impacts to public health. And so in this way, I think, air pollution is on one hand, it's a climate mitigation issue. It's aligned rather with climate mitigation in that if we change emissions, if we decrease emissions, it'll have an impact both on greenhouse gases as well as air pollutants. But it's also a climate adaptation link as well, in that if we can improve air pollution, something that's within our control, we know some level of climate change is coming that will have negative health impacts, but we can still improve air pollution. So that's not an added stress. So we can help to adapt to the unfortunate coming of some level, or the presence even now, of some level of climate change. And so air quality really has linkages across both of these aspects. Because of these really strong linkages, there are solutions to benefit both air quality and climate. But as I noted, not all are always win-wins. This figure here tries to map out what are win-wins, what are lose-loses. In general, the lose-loses for both air pollution and climate change sit in this quadrant where we use a lot of fossil fuel. That's not good for either of them. One of the examples of an air quality benefit, but it can be a climate change detriment, an example would be flue gas desulfurization. So this is what you could put on ESCOM, say, something to get rid of the sulfur. So if it gets rid of the sulfur, that's very good for air quality. However, sometimes it can also lead to more usage of fuel, which would then release more GHGs. In general, those that are win-wins are ones that move away from using fossil fuel burning. And these are, this isn't really quantified here. These are just examples of these different quadrants to really also highlight that climate policies, which sometimes unfortunately can, not drive air quality policy, but are sometimes given more attention than air quality policy. Not all climate change policies will be beneficial for air quality. And so this is something that really needs to be thought of when these policies are developed. But one thing that is good for all of them is moving away from fossil fuels. And in particularly moving away from coal-fired power stations. This is a global analysis, but I know there's a lot on here. These guys that are good for CO2, good for health benefits, are moving away from coal-fired power stations. But I do want to note that that's not the only thing that we can do. So I have said, we can improve air quality. A lot of the time, this discussion focuses only on electricity, but we've done modeling to show that even if we turned off ESCOM did not emit anything, we would see very small changes in the pollution level at ground, particularly for PM 2.5. So this is an analysis of PM 2.5. I've circled here at the bottom the key aspect, which is the difference between when we ran our model with ESCOM on and then we turned ESCOM off. This is the Highfeld. You can see Johannesburg, Tshwane, Ekurhuleni. This is what is the change in the PM 2.5 annual average. And it was about 3 micrograms per meter cubed, those dark blue areas. That is an impact, and that has an impact on health. However, our exceedance levels are not just 3 above our standards. We need a lot more than that. And so we need actually a lot more aggressive action across a lot of different sectors. And this kind of also can bring us to the just energy transition. The just energy transition, right, in South Africa in particular, is something that's talked about quite a lot, very often from sustainable jobs, from a climate aspect. But I fear that air quality gets lost in this. Because when we get to the end, if we achieve all of our just energy transition goals, the air pollution will be better. If we decarbonize our economy, air pollution will be better. However, there are things we can do now, and how we do this transition really matters because we need action across sectors in order to improve air quality. And this I'm showing through an example of work we've done in Gauteng. So what this figure is showing is kind of on average, what are the sources of PM 2.5 in Gauteng? And the different colors are different sectors. And so in general, there's about, and this is, there's uncertainties with this, on average per year, around 5 micrograms per meter cubed would be from natural sources, be that dust, felt fires, other aspects. Some of it comes from outside of Gauteng, but a lot of it then is generated within Gauteng. And the thing with air quality management, as we see here, there's not just one color, which is the different sectors, that if we reduced it, we would meet all of our, we would fix the whole problem. Rather, it's across many different sectors. And we have to have really large decreases in order to meet our standards. As an example, our standard currently is 20. So you can see here already with natural, we're at about 5. Outside of Gauteng, maybe we're about 12. It doesn't leave much for, the 15 million of us that are living in Gauteng. Again, there are uncertainties in here, but still, order of magnitude, we can get an idea, of the level of action that is needed. In 2030, our standard is going to be 15 micrograms per meter cubed. And so again, if outside of Gauteng natural sources don't change, and natural sources are difficult to change, Some of them can be dust, but as I said, some of them are like felt fires. We can't control felt fires in a way, very, very easily at least. And then the WHO guideline is around 5, which, even within uncertainty, the modeling of that within this urban area just is not even possible due to natural. And that's true of many arid and semi-arid regions. But I wanted to highlight this just to really show that a lot of the different sectors, we need action, and we need really aggressive action. And so waiting and thinking, because air quality very often gets tied with climate change, but we need to kind of get it out of there in order to have action on it now, as we also have action on climate change going forward. And this is also an environmental justice issue. I haven't come back to this many times, but I noted at the beginning that we do have this air inequality, where our most vulnerable communities, low-income communities, often have the largest levels of pollution as well. And just to show the details kind of behind what level of emission reductions we might need, also from this project, and this is a very busy slide, but I just wanted to highlight this last column with the percentages. These are, if we wanted to meet our standards across Gauteng, what level of emission reduction in percentages do we need? You can see these are all really high percentages. This is just PM, but we also need it across other pollutants as well. So the small incremental changes aren't really going to get us where we need to be to improve air quality. We need more aggressive action. And so that's really where I'd like to end it. I hope I've provided a little bit of context of the different way that these are linked together, shown that we know the sectors, we understand within some uncertainties what is contributing to pollution, and we need actions across the sectors in order to improve air quality. And hopefully now, not waiting until we, our guides are not until we have our climate change goals of decades from now. We can also make changes really now to improve health now and also into the near term. So thank you. I'd like to end with that.
Thank you. Thank you so much, Professor Garland.
Oh.
Decided there.
Okay, it's not me.
Yeah, it's disturbing to hear that our policies are so good, but the enforcement or sticking to them, something. And I wanted to ask a question to both of you, but before I do that, just a quick reminder that there will be a poll popping up a little later. Thank you. I think you've clearly illustrated how everything is connected and the linkages. I wonder if for a moment, because the science that you presented is complex, worry, everybody will get a recording, so we could listen through the simplification and ask each of you, I'll start with Professor Peter, to say, obviously lung disease existed before climate change. Can you help us separate out what about lung disease might have still been there if there was no climate change, if we can imagine a parallel universe? And what about it is so much worse? Just as a really simple way, I think perhaps to summarize what you've said earlier, Professor Peter.
Yeah, no, I think that's absolutely right. I mean, I think there's the human aspects, the genetic background of people. I mean, we know that there's a genetic predisposition to be allergic, if that makes sense, and to have asthma. They are quite strong drivers. And then there are other kind of comorbids, like I mentioned, the changing of weight, dietary factors, those are important aspects. And then, of course, the social inequality, those social determinants are important aspects as well. Now, where it becomes then I think I like to see it sort of like that. So that's sort of individual aspects that drive certain respiratory diseases. Then the next aspect I like to think are all these environmental exposures. And now, what's quite hard to unpick is obviously, living in certain informal settlements, burning, we've spoken to communities, for instance. I was interested in Rebecca's comments about the fires and the garbage, because one of the things communities that we've spoken to are most interested in is that people are burning their garbage right in their communities. And that's actually what they're breathing in, and that's impacting them. So, so I think that becomes harder to unpick from exposures, because those exposures are then impacting. But then I think when we're reporting it, we must talk about those relationships, which in the science are quite strong. Then when what becomes a bit more tricky is to unpick how is the changing climate driving those factors. Do you know what I mean? And so absolutely, as you say, I think it's important in the way we're reporting it to acknowledge that there are endogenous factors, there are like community level exposure factors, and then some of those are pulled by climate.
Right. And how would you simplify that term, endogenous factors? How would we speak to our audiences about that?
I would say they are related mainly to our genetic background, and our own, or like sometimes we refer to it as the host. You know what I mean? Like your own body's factors that determine what illnesses you'll get, and
Sure.
how your lungs will function. Like, for instance, and I think that's how you should phrase it. There are definitely factors. But where it becomes tricky is those two things are interlinked. So there's a very prominent researcher, Heather Zar, who in South Africa been running these birth cohorts for childhood lung health, and they have lovely data to show that if that poorer communities, it impacts maternal nutrition. And I saw some colleagues in the comments talking about their programs on maternal and child health, and those impact starting off birth lung function. So your actual lung function, your innate ability of your lungs to work well and to be strong relative to the exposures that they will encounter, is actually affected by what goes on in your maternal environment, what goes on in your communities. But certainly they are contributing. So,
For sure. And to Professor Garland, if you would imagine, I guess maybe a simplified question of perhaps summarizing what you've said is to say, obviously climate change is creating new pollution problems, or is it perhaps mostly an amplifier that makes these things so much worse? To what extent is it creating new problems, and to what extent is it amplifying?
That is a really good question. I don't think we know for certain necessarily, but mostly it is amplifying. And that is something we see in climate change in general, right? From the heat, from most things, it's where we already have these problems, it's going to get worse. Now, for air pollution, we don't necessarily know if climate change, because it's so complex, we can't say, yes, climate change will make this pollutant worse, this pollutant better, this. We don't have that level of understanding. But we do know that if air pollution levels stay high and we have the health impacts from climate change together, we are now putting more burden on people's health, right? We do understand that. And so I like to think of air pollution, like I said, from the climate adaptation angle of let's try to improve air quality so we take away some of those stresses. So I would say mostly it's not creating new things we don't know about. It might be impacting air pollution in a way we can't fully quantify, but it is most likely going to exacerbate the problems we have. And so let's deal with the problems that we have.
A lot of times what journalists try to do is to pre-bunk misinformation. And we know that there's a huge amount of climate change misinformation, skepticism, and downright, going in the opposite direction happening, unfortunately. And so the nuance that you've both just spoken about is very important to explain, but quite difficult to explain. It can, if you're not careful, sound like, oh, climate change is not really a factor. Or it can sound as if we're claiming that climate change is the only factor. So if either of you would just like to help us through how to report on this story with credibility, acknowledging the role of climate change and of science and all the great science being done, not making it too complex for our listeners or viewers or readers, but saying what needs to be said. If you would give it a try, we'd be grateful.
I'll have a first go at it. So I think it's partly related to the questions you've just been asking to us. So I would say that if you take a respiratory disease like asthma, the first thing to do is to acknowledge the human factors, right? So that's like we talked about, one's own body, and then all of the things that humans do and would do in whatever climate you're talking about in a way, right? And then to what I've learned a lot in the climate space is really to be careful in reporting about longer term changes to the climates. And what I've learned about the climate scientists is they're talking in hundreds or thousands of years. And then the short term effects of climate. Like, for instance, I think that, our relationships are very good to show, like I showed on that slide, when there's a heat wave, like we're having in Cape Town, there will be impact on respiratory disease. But what's interesting about a heat wave, which I also learned recently, is that, the way that it's defined, 3 days with a 5-degree heat above the maximum temperature for that place at that time. There are all those like provisos, so I think that the detail does have to come through, but I think, trying to break it down into those things, saying, okay, what part of this is host and the disease and the human factors that we'll be doing independent of climate or whatever climate we living in, and then trying to distinguish, okay, these are short-term climatic events that impact these health outcomes and exposures. And then if the data is there, making that comment about climate change. So like, for instance, there is data now. Rebecca probably knows this data much better, but we've been looking at this for extreme weather events like heat, that those are becoming more frequent in South Africa. You know what I mean? And so you can actually just report that. We've noted, there is data, here's the reference, that these extreme weather events are becoming more frequent. And there is strong data that when there's a heat wave, this is what happens to respiratory health. I think those pathways are very robust and very clear. I think, the reasons, the kind of climate drivers, and maybe Rebecca's got a way to respond to that, being sure that you report that accurately on why are heat waves becoming more frequent. Maybe Rebecca, you've got an answer for that. How do they report on that? Rebecca, are you there?
She looks frozen.
The question froze us. Yeah, but I think so. I mean, maybe when she comes back, she can comment. Rebecca, are you still there? Yeah.
So I mean,
and so that's like, for instance, I use a very specific example because I also think that is very helpful. Instead of using broad reporting, to use a specific example, like, we're interested in asthma for those reasons I've provided in the talk, and then talking about a very thing like, okay, climate change is driving heat wave to be increasing or extreme weather events to be increasing. And these are the links to the respiratory event. That kind of reporting, I think, is very powerful. Because it can't be, it's less susceptible to criticism, right? The difficulty is, I understand the reverse, which is kind of we want to make sort of these grander statements, and I think that's where people take umbrage potentially. I think Rebecca's back here. Maybe she can comment.
I don't know if you heard the question. Hi. I think what I actually would like to pose another quick question, because it would be great to give the audience members, everybody who's joined, a chance to ask questions too. So I'll pose a new question and simply, related to something you said, Professor Garland, and this is about policy and the poor following of policy. It just seems like to be a problem that comes up all the time. Now, who can police the implementation? Who should and who does police the implementation of policy? Because it's sad to hear, and we know from statements being made that there is strong commitment to, to many of the things we mentioned today, and to, mitigating climate change at least. How can it be policed, Professor Garland?
Sure. So I will say I'm an atmospheric chemist. I do not fully understand policy, but I can explain my understanding of the difficulties. And from the policing of it, from the enforcing of it, the struggle is that, from my understanding, and from what I've seen when talking about these documents, is the DFFE, our environmental ministry, they are the ones that create the plans, that create what should happen. But the implementation is in other sectors. It's DMR, it is Department of Transport. So DMR, the mining, it's transport, it's other aspects. And this was something that came out in the constitutional case in the Highveld, the dirty air case, that the one thing the judge, one of the recommendations specifically that the judge noted, that I noted that she said, was that we have to get the sectors working together. So that was, a case against the government in general. And we can see this happening in urban areas and many areas. It is, and I think, unfortunately, right, this happens internationally. It's the Environment Ministry, and they can try their best to enforce it and create these, but then it's all the other sectors have to come to the table in order to actually implement these. And for that, unfortunately, similar to climate change, it's not always the top of their priority. But that said, as as I showed, and then Jonny also noted, things like service delivery do have an impact in low-income communities. If waste is collected, which it is many places, but there are issues with it. If waste is collected, it won't get burned. If there's cheap, electricity, if there are ways for people not to use solid fuels in their houses, people can do that. So there are also levers that can be used that aren't necessarily then maybe just these kind of national sectors have to come together.
Yeah, and as you mentioned also, these sort of local forms of monitoring that will certainly be helpful, at least in terms of, what it feels like to be living with asthma or another lung disease. So there's the poll. By the way, please, everybody who's on the line, please fill out the poll. It really helps us improve the webinar. We're going to go to questions from all of you now. Do please, do please enter the poll, really asking nicely, because then we're going to do more of these, and then we'd know whether we, fulfilling your needs or not. I know that there were really great questions submitted with the signups, but rather than going to them now, let me rather ask anybody on the floor, anybody attending, to just put up your hand and appear and ask your question of either Professor Peter or Garland, please. Let me see if I can see the hands.
Gosh, thank you.
Yes.
I thought one question I wanted to talk about was a question that was put into the chat a little bit earlier about, and this is something that I think is quite a important topic. So the question in the chat was around a person from the Grow Great campaign, and was talking directly about interacting with children and mothers, and kind of interacting with what to tell people. And so because I think this feeds into what you were asking about, not making sure that this is not just a doom science story. I think Rebecca's highlighted kind of local things that people can do, but we also have several of them too. So part of the reason we put the pollen count website data up and make it available and on our website, we have, for instance, a traffic light system where it shows like when the levels are into the red range or orange range where they could be causing people symptoms and when they aren't. What we found, and this data was actually published, was around simply wearing a mask and being aware of outdoor times during the times where pollen is very high. Similarly, if individuals are empowered around their asthma care, with that slide I showed around the smart therapy, literally individual level instruction and knowing what your triggers are. So if you are, happen to be near a wildfire, a felt fire that you can't control, well, actually upping the dose of your medication can actually be the thing you need to do. And for instance, as well, the South African Weather Service does host the South African air quality metrics. And, there is problems with those data, but there at any given time, you can go to that website and you can see areas. And maybe Rebecca's got a comment on that. But, there are some measures already that enable people to take action for their individual health. And I always like to try to offer that to people. And then the other thing as well is that, I think that, again, stressing what we were talking about earlier, which is this combination between your individual susceptibility, potentially your host, and the risk and the environmental exposures are, important to kind of quantitate the amount of risk rather than just coming of the doom and gloom. Because I do really empathize. I think it's very tough for, mothers trying to do their best for their children and then getting told, can't breathe this air, can't do this, can't do that. I think that's really tough, and I think we've got to strike the balance between helping individuals to live in the world and do their best, and then also being sure that we create enough data that we can advocate for policy change. You know what I mean? And that could be at all levels, community level, and at a higher kind of governmental level. And I think there really are things that you can do all the way along for individuals to do, for advocacy groups to do, and for kind of policymakers and government to do. I don't know if Rebecca, if you've got additional comment to that.
No, I just put the link for the South African data, and I'll also provide a link for global data as well, so people outside of South Africa.
Perfect.
Thank you for that. Yeah, I think let's go to, I see one hand up, James Erlam, but just before that, there's a great question by Chepo Mukhadi related to the data that you just spoke about. And it is, how significant is the gap between our official statistics and the actual on-the-ground prevalence of asthma? And what was, Chepo, if you are there, you can just add your voice to this and say what question you really would like to have answered, please.
Yeah, so I mean, so just to comment on Chepo, that comment, it's a good question. So I mean, the data that I'm showing about the prevalence is about, I think, quite close to being as accurate as you can, in the sense that it was quite a recent study that I'm showing you about KZN. Now, obviously, we do have, unfortunately, asthma is not one of the kind of key National Department of Health indices. So, unlike we track, for instance, we got very good data on TB cases in the country. Asthma is not something that at the kind of primary care level we are collecting data on. Now, we're trying to advocate to change that, and certain public health systems are starting to keep that data. Like, for instance, the Western Cape is working quite a lot on ICD-10 coding for asthma. So, that data should emerge. And we've got a project now. So we've got a Wellcome Trust grant that is working, and one of the goals of this grant is to get national level asthma data from private medical aids. So, for instance, we've got a project now working with GEMS, where we are hoping to get asthma prevalence data from across the country, and that should be a very accurate real-time data, and that will allow us to do some of the work that we're planning to do, which I mentioned, like identifying particular hotspots in the country, and we'll be able to, for instance, there isn't even data to say on those lovely pictures Rebecca was showing, we can't even put the asthma data at the moment onto those pictures. So that's kind of one of the things that we're planning to do, because there's a lot of great data, and Rebecca's actually part of our project. So that kind of modeling would go a long way to helping us be more accurate. And I guess what Chepo's getting at is kind of like on the ground data. So I think there are big gaps at the moment, and hopefully we'll plug some of them.
That's wonderful news. Thank you very much. I'm going to ask James to ask his question, but just before that, to ask also, when we share the recording, maybe we share both of your email addresses as well. So I didn't ask you in advance, but it's so useful for journalists. And I mean, I see there's a lot of interest, lots of follow-up stories emerging from what you've both said. So we'd love to. Thank you. Is that a yes? Great. Okay, please go, James.
Okay. So thank you to both of you and Ida for this very informative webinar. Jonny, great work. I think you've answered some of my questions around the data, and the pollen count tool does seem to be another means of eliciting data perhaps from users. And then my question was also around what are health professionals being taught about climate change and asthma. What should they be taught more than they're currently getting, given their important role in protecting public health from climate change, and also trying to reduce emissions from the healthcare sector itself?
Yeah, great question. Great question, James. And I know we're working on this before, and you're leading that planetary health adjustment to our curriculum. And I think that's absolutely critical. I mean, I think that the short answer is that I don't think that certainly we doing undergraduate teaching from my department around allergic respiratory disease have a very narrow window. We spend a lot of the time that we do have teaching people just the basics of, what I explained about what is asthma, what drugs do I use for asthma, how do I treat asthma, that kind of asthma case. And I think that's probably where we need to be strengthening out a little bit more data that we are starting to get, like I showed in some of those slides about the links with different environmental exposures. I think that data could be, and that training could be strengthened. And then I think a whole nother part, which I think probably deserves its own kind of focal point in undergraduate curricula, is what you are working on, which is around how do the health profession itself become more sustainable and more conscious of its impact. I think that's something that we being asked to do that more in research, actually very interesting. Now, if you put in a grant to an application to the Wellcome Trust, they ask you, how is your research unit more sustainable? How is it promoting, these things? And I think that's the way that it needs to go. And I think that needs to start coming in. And I would strongly argue as well that this is not just something for kind of health professionals that may become hospital workers. This is very primary care focused, and I think it should also be integrated into nursing curriculums and across the board health professions in general. I think that's kind of critical.
Many thanks.
Sorry, thank you. Thank you very much. I see there's a raised hand from Adele Baleta. And after that, I would like to ask Ntando to comment more on his comment about the fact that a lot of community engagement will be needed, because it's a whole new set of messages that people need to hear about how to behave, how not to behave, how the science works, etc. So Ntando, if you are available later, please do. And let's go to Adele for your question, please.
Hi, everybody. Can you hear me?
Yes.
Okay, good. Thank you very much, Jonathan, Rebecca, Ida. Great seminar. I just want to sort of maybe expand on what James has said. And, you were talking earlier about collaboration, okay? And the one thing that I feel like needs to happen, and I know this is a monumental task, okay? So I love the idea of training at varsity level or whatever, sort of public health to be officials. But I really am concerned about reaching decision makers, because that's where policy change happens. And I don't think that that's happening. And what I'm talking about is actually in the Department of Health, because I don't really get that sense that there's an understanding or there's action around the working together between environment and public health. So I don't know how you do it, but in some ways, I think that's where we have to go in some ways. And maybe I think journalism to a large extent can actually start asking those questions. I just thought I'd want to know what your thoughts are about that.
Rebecca can comment, but I can comment just from my own experience with our current SA Cares project. And I think that what's great is I think journalism has a big part in this. I do think we're getting momentum, like the public voices are getting stronger. Obviously, there's dissent in certain areas, but I think overall people are trying to pull in the right direction. And I was very encouraged. I got invited to present to the One Health policy unit of the Western Cape government. So that is a cross-sectoral group now that is involved in making policy around One Health, and climate is integrated in that. And what's nice about that, and the reason I kind of am flagging it, is because it is across sectors. So it has like air quality, urban planning, health. So, and I'm probably leaving out 10 other sectors that are there, education, so I think there is kind of some direction. This is the first one I was invited to, which is the Western Cape. We have been engaging, and Rebecca probably knows more about this, with air quality specialists and divisions across the country. I think, like Department of Health data, there's a lot of variation across the country, but I think there is a start in happening with that. Becca?
Yeah, and maybe just to add on that, the examples that I've seen, particularly climate, air quality working closely together, are in the cities. I think the cities are really driving this both such as Durban, Tshwane, Joburg, many cities, Cape Town as well. And that's, part of it also where we say, right, the rubber hits the road. You have urban heat, you have climate change, you have poor air quality, everything's there. There also is, as Sarisha noted, there is a focus group run by the Department of Health of Air Quality. And then also another real positive that happened last year is within the G20 presidency of South Africa. It was the first time ever that an air quality statement was made. I was part of some of the expert panels to discuss this. And I know we're talking about climate change, but why that was so important is we did pull air quality out, that it's not, the bridesmaid of climate change. It is an issue in and of itself that needs attention now, as I was saying. So kind of also, in some ways, pulling it out as a standalone issue, I think helps hopefully spur action on that. Then, while we also worry about climate change, we can't forget about that one as well.
Thank you.
We're close to the end. Are you there, Ntando? I don't see or hear him now, but the point he was making was about all the community engagement that needs to be done. And I actually think that point, together with mentioning policymakers, mentioning those in the health field, and when it comes to policymakers, of course, all those different departments that you mentioned, and then community engagement, in other words, us, ordinary people, these all need to know more about these issues, need to care more, need to understand why it matters. And that's where journalism comes in. I mean, all of those sectors of society read some form of journalism, or listen to the radio, watch it on TV, read it online. So that's how we can reach all of them. So I'd really encourage you to do stories about this, reach out to the two experts we've had here. It's time to end, and to also thank you both very, very much, Professor Garland and Professor Peter, for your expertise, for being available. Thank you, everybody, for joining, for your wonderful questions that really inspired us in putting this together. Thank you for attending, and of course to my colleagues at Bheki CISA. So wonderful, wonderful, and let's hope to see those stories about this issue appear in the media. Thank you.